Okay, welcome everyone. I'm Dr. McKinley at St. Mark's Hospital. I'm going to be talking about our weight loss surgery information class. We have some objectives here. The first thing we want to do is talk about obesity and treatment options that we have for obesity. We want to talk about when to consider weight loss surgery, the different options that there are available to you, and to help you choose your weight loss surgery path. So as many of you already know, obesity doesn't just affect your health, it affects your overall quality of life. And frankly, being overweight or obesity is misunderstood. Many people consider it a cosmetic problem when in fact it's not that at all. It's more of a complex disease that has a lot to do with genetics, the environment. It certainly has something to do with diet and lifestyle as well, but we see it as more of a complex disease as opposed to a personal failure or lack of motivation. That's not the story. So our program is customized to support you whether you choose medical or surgical options, where you can be surrounded by professionals, caring providers who want the best for you and to help you meet your objectives. As you may be familiar, there are several health conditions that are related to obesity that can lead to a decreased quality and frankly quantity of life. And these conditions involve high blood pressure, sleep apnea, where you may forget to breathe at night, your body just doesn't breathe as easily, heart disease, diabetes, and even some forms of cancer. All of these can be related to being overweight. So the body mass index, or BMI, is a term some may be familiar with, but just to describe what it means, it's when you take your weight and divide by your height using the metric system. So your BMI is going to be a metric or a measurement of your weight, but taking your height into account. So we offer medical weight loss solutions for those with a BMI of greater than 28. And again, this is medical weight loss. This includes a nurse practitioner, a dietitian, and behavioral specialists that can help you with weight loss. As far as who can be a candidate for surgery, we follow guidelines that have been recently published by our American Society for Metabolic and Bariatric Surgery, as well as the American College of Surgeons, in that those who are candidate for surgery include those with a BMI of 40 or higher, with or without a medical problem. So that would be, for example, someone who's 100 pounds overweight or more, and they may or may not have diabetes or high blood pressure. For someone who has a BMI between 35 and 40, they would need a comorbidity or a health condition such as high blood pressure, sleep apnea, high cholesterol, high triglycerides, or joint disease. And then new guidelines suggest that even with a BMI of 30 to 34 with type 2 diabetes would be a candidate for surgery. Here at St. Mark's Hospital, we have a comprehensive program of both surgical and non-surgical options with a team of experts, again, ranging from surgeons to dietitians, nurse practitioners. If you choose to have weight loss surgery, we hope that you choose to have surgery at a designated center of excellence. St. Mark's is accredited by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. It's a long term, but basically it means that we have people come out about every 3 years to evaluate our program, ensure that we are providing the highest standards for our patients. We are a comprehensive center with both medical weight loss and adolescent recognitions. So we will treat patients who are in the teenage years. We are recognized by multiple payers or insurance plans for their bariatric surgery excellence programs. So if you weren't to choose St. Mark's Hospital, we would recommend that you do choose a center that is accredited to ensure you're having surgery at a high quality program. Thank you for paying attention so far, and now we're going to turn the time to some of the other surgeons who will talk about the different surgical options, including sleeve gastrectomy, gastric bypass, duodenal switch.
Hi, my name is Douglas Greer. I'm a bariatric surgeon here at St. Mark's Hospital. Today we'd like to talk to you about the sleeve gastrectomy. Sleeve gastrectomy is a surgery that we perform here at St. Mark's. What we do for the sleeve gastrectomy is we are going to make you a smaller stomach. So if you imagine that your stomach is the shape of a football, when you leave the operating room, your stomach is going to be the shape of a banana. Now we do that by using a combination of a surgical staplers to both seal and cut your stomach. We then remove that portion of your stomach, so this is considered a non-reversible surgery. Now this is the most frequently performed bariatric surgery in the United States. is very safe surgery. Now, what we expect for weight loss with this surgery is we expect you to lose about 50 to 60% of your excess body weight. Now, what do we mean by excess body weight? Each person has what's called an ideal body weight that's based off your gender and your height. We take your actual weight and then your ideal body weight, we subtract that, and we get your excess body weight. We then expect you to lose anywhere from 50 to 60% of your excess body weight after this procedure, and then we expect you to keep that off for upwards of 5 years. Another major benefit of this surgery is that we see with patients with type 2 diabetes, we see 70 to 80% resolution of their diabetes at 2 to 3 months after the procedure. So some pros of the sleeve gastrectomy: so there are no foreign bodies with this procedure, such as we may have seen with other procedures like the band. Another pro would be that we are not going to change your bowel anatomy, meaning that food goes in at point A and leaves at point B the way it always has. We're not going to do any bypasses. Another pro would be that this is our procedure that has the lowest vitamin deficiencies, also the lowest risk of any malnutrition. Another pro would be that we do have some outpatient surgical options for this procedure as well, and not all of our patients have to spend the night in the hospital. So what are some cons of the sleeve gastrectomy? So this is considered one of our newest surgeries, so we have been doing this not as long as we have with some of our other procedures. So we don't have some of our long-term data. We don't know how some of our patients are doing 15, 20 years out from surgery because we haven't been doing it for that long. So we don't know what some of the long-term ramifications of this surgery is. Another con is we do have a risk of complications such as a staple line leak, where you can risk of infection inside of your abdomen. This is very low at less than 1%, but this is a risk. Another risk would be a stricture or a narrowing of the stomach, also very low at less than 1%, but this is also a risk. And then another con is that some of our patients that have really bad heartburn, they could have worsening symptoms, or some of our patients that don't have heartburn could develop heartburn early on after the procedure. So who is a good candidate for a sleeve gastrectomy? So patients who are risk averse. This is our surgery that has the least amount of risk, both with immediate postoperative complications as well as long-term complications such as our vitamin deficiencies and malnutritions. Patients who have had previous surgery on their intestines where maybe a bypass procedure is not possible. Also our patients that have certain diseases that may require for future bowel resections in the future, such as certain genetic colon conditions, may also be a better candidate for sleeve gastrectomy. Also patients that they're immunocompromised, specifically patients that may be on a transplant list, that may be in line for a kidney or a liver transplant. This may be the best option for you. And then also our patients that are very overweight, that are considered to be malignantly obese. In some cases, we do a staged procedure where we can first do a sleeve gastrectomy to help you lose weight, and then prepare you for doing a more radical procedure such as the duodenal switch.
Hi, I'm Dr. Nick Polk. I'm one of the bariatric surgeons here at St. Mark's Hospital. I'm here to discuss the gastric bypass with you all today. The gastric bypass is a procedure that has been around since the 1960s. It is by far, throughout time, the most commonly performed bariatric surgery. We've been doing it laparoscopically since the mid-90s. We found that when we transitioned from doing big open incisions to these small laparoscopic incisions, it really decreased complication rates. It has a great track record. What we're seeing is that people can lose between 60 and 80% of their excess weight 5 years out from surgery. Now, as you may be aware, excess weight is defined as the amount of weight above your ideal body weight that you currently are. So say your ideal body weight was 100 pounds and you weighed 200, it would be 100 pounds. So, you know, that helps to define, because as we talk about how much weight somebody could reasonably lose after one of these procedures, you could kind of do that calculation for yourself. And, you know, while that's a pretty big range, 60% to up to 80%, I usually tell people just go with the middle, about 70%. So if my excess weight is 100 pounds, I could reasonably expect to lose about 70 pounds. In addition to the weight loss, we see a pretty remarkable improvement in diabetes, specifically with this procedure. And we believe that's because food is not allowed to go through the duodenum portion of your small intestine. So, when we talk about, well, what are the pros of the gastric bypass compared to other procedures? One, as I said, it's the gold standard. We have got, 80 years of experience with this. We've got good long-term data and follow-up, and we know what to expect. There aren't things that are popping up that we didn't know we should be watching for. In addition, this is a very durable procedure. With any bariatric procedure, we do over a 5, 10, 15-year period see some weight regain. But compared with other procedures, this particular procedure has a pretty low likelihood of weight regain long term. People with really horrible reflux prior to surgery who are considering, should I get a sleeve gastrectomy or gastric bypass, and they see that with the sleeve gastrectomy, there's a high likelihood that their reflux is going to get worse. It's a natural decision then to say, well, maybe I should get a gastric bypass instead, because this takes care of both problems. Drawbacks or cons of the gastric bypass. We do worry a bit more about absorbing certain vitamins and minerals. With all of our procedures, we are going to require that people take a regimen of vitamins, a daily multivitamin, sublingual B12, and like a chewable calcium daily. And what we find is that people that take their vitamins, less than 3% of people will develop vitamin deficiencies. However, we do see it occasionally. And that is one of the things that we watch for specifically a little bit more with the gastric bypass compared to the gastric sleeve. Dumping syndrome is another big potential drawback to a gastric bypass. And essentially what happens with the gastric or with dumping syndrome is if you have a high carbohydrate meal or sometimes something just very greasy, there's no valve at the end of your gastric pouch. It's just it always stays open, and it drains by gravity, and sometimes that can go too fast. And if you get sugar down into that lower part of your small intestine, your body has to pull in a bunch of fluid from your bloodstream to dilute that food, and that makes you feel awful. Usually people say it's not really painful, but you just feel really bad. You get maybe a little bit sweaty. You got to go lay down for 10-15 minutes until it passes, and then you kind of start feeling okay and get back to normal. But it's a really unpleasant experience. Now, some people say, well, the good news about dumping syndrome is that it keeps me honest. I'm not supposed to be eating those things anyway. But, it's absolutely true that after the first year of as people go through the weight loss phase of their surgery, we do tell people, hey, from time to time, you can have a bite or two of this or that, a dessert at a party or something like that. And for some people, not being able to do that because it might make them sick is a really big consideration. So we want people to think about that before surgery. The next one is where we're dividing your intestine and making connections. There is a chance for any of those connections to break down and you have a leak. Fortunately, the leak rate is very low. It's less than 1%. It's about actually 0.7, 0.75% in that range. However, if that happens, it is absolutely a trip back to the operating room. We need to get in there, potentially put stitches in where it's leaking and clean things out. So, that's a major complication, and that possibility we want people to consider. The other maybe more common issue that we see with gastric bypass is strictures or tightening at the connection between the stomach pouch and the small intestine. Now that happens because of scar tissue. We make this round connection between your intestine and the pouch, and the way your body heals any wound, even ones that we make on purpose, is it puts down scar tissue, and then scar tissue over time can contract. And if it contracts too much, people start noticing food just feels like it gets stuck right behind their sternum. that most commonly happens around 1 month, about 4 weeks after surgery. If it does happen, we can take you to our endoscopy suite and put a scope down through your mouth and stretch that out. And that solves the problem. It breaks up those scar tissue fibers, and now you're a month down the road, so it's mainly healed. You don't get in a bunch of new scar tissue, and people kind of end up being back on track. Additionally, that can happen down the road if people develop ulcers. This is the big reason that we tell people, hey, regardless of which procedure you have, no NSAIDs after surgery. And that's hard for a lot of people that have joint issues, whether it's arthritis or just overuse injuries, etc., because that's kind of the mainstay of how you keep your pain in check at this point. So if we say no more NSAIDs, that can be problematic. But taking NSAIDs just absolutely skyrockets your risk for getting an ulcer and having these types of problems, even years out from surgery. Finally, where we divide your intestine and make a new connection down lower, that can generate scar tissue and some other scenarios where it can cause a twist or a kink in your bowel, and that can lead to needing to come back to the hospital and having another surgery. Fortunately, the risk of that is pretty low. It's 1 to 2%, and that's lifetime risk, which tells you two things. One, it's a low risk for any chunk of time, but this is a risk. This could happen 8 years, 10 years down the road as easily as it could happen 8 months down the road. And so, that's something we always kind of have to be wary of. These many of the other risks like leaks, bleeding, and so on, if that doesn't happen within the first 30 days, pretty unlikely that it's ever going to happen. So people who generally tend to gravitate towards the gastric bypass are people who want a little bit more powerful procedure than they get with the sleeve. So there's more metabolic effect. Type 2 diabetics, because this is a bit more effective at not only treating it up front, but keeping people diabetes free long term, tend to lean towards the gastric bypass. And finally, as I mentioned earlier, people with severe reflux tend to choose the gastric bypass because it stops the reflux and it helps with the weight loss.
My name is Stephen Semper. I am a bariatric surgeon here at St. Mark's Hospital. I've been performing bariatric surgery in one way or another for over 40 years. I've been asked today to discuss the duodenal switch, which is one of the 3 operations that we offer for weight loss here at St. Mark's Hospital. Duodenal switch is our most powerful tool. It combines reduction of the stomach with partial bypass of the intestinal tract. They talk about it being a combination of restriction and malabsorption, but we don't like to use those terms anymore. These are metabolic operations, and this is our most powerful metabolic operation. By metabolic operation, I mean that these operations actually alter metabolism. Your gastrointestinal tract appears to be your metabolic organ, not your thyroid, not your pituitary, but your gastrointestinal tract. And that is how we believe these operations work, and the duodenal switch is the most powerful of the 3. It was first done in the 1980s. It's been done here at St. Mark's Hospital by me laparoscopically since 2006. Weight loss is excellent. On average, patients lose greater than 80% of their excess body weight. And diabetes resolution, which is a measure of the metabolic effect of these operations, and by diabetic resolution, I mean the diabetes going away. We see that in about 95% of our patients by 2 weeks, and most of the time it's almost immediate. 2/3 of our patients do not go home from the hospital on medications. That's how rapid it is because it's a metabolic effect. The duodenal switch is our most powerful tool. It has the best weight loss, best durability, best comorbidity resolution. That being said, you don't get anything for free. It also carries with it a little higher risk. Has the most metabolic effect. It may even be too powerful for a very small number of our patients, but it can be modified if need be. But it's rare we need to do that. There are less dietary restrictions than with the gastric bypass because we do not worry about dumping syndrome. That being said, the diet recommendations that we have for all 3 of these operations are basically the same. It also lowers triglyceride levels better than the other two operations, although they can be beneficial. This one lowers the most. So if you have severe hypertriglyceridemia, again, if you don't know what I'm talking about, you probably don't have it. This operation is the one that's the most effective at lowering those triglycerides. Downside, again, because you're bypassing much of the intestinal tract, then there may be some degree of malabsorption. And therefore, you run a small but increased risk of nutritional problems, particularly protein malnutrition. If you look at carbohydrates, you actually absorb carbohydrates pretty normally because they're so readily broken down and so readily absorbed. Protein absorption after a duodenal switch, everything in biological systems is a bell curve, and therefore this is as well. We see that probably a third to half of our patients show no evidence of any type of malabsorption, but that means half to two-thirds may have some. When it comes to protein, they decrease their protein absorption somewhere between 10 to 30%, but most people consume plenty of protein, so that's not a big issue. Fat absorption is decreased somewhere between 30 to 80%. Again, that's not a big issue, except that the large intestine does not like undigested fat, and eating a high-fat diet can lead to gas and diarrhea. Because it is the most complex operation, as I said, there is some downsides. It has the highest surgical risk. Not a lot, but a higher surgical risk of complications by a percentage point or two. Because of the fat malabsorption, there's a risk of having foul-smelling gas. And that can be a problem. Again, usually can be controlled with diet. There's also a risk of foul-smelling diarrhea, and that goes along mostly with diet. And we'll talk a little bit more about that. Because of these long-term risks, it's an absolute need to follow up with somebody who understands these operations. Not necessarily a bariatric surgeon, as I can educate any primary care doctor in a 10-minute conversation about what to monitor, but they need to stay in contact, and if there's any issues, get back to us, and because we have solutions to them. This operation is not reversible, but it can be modified if need be, but it's rare that we need to do that. Complications, because it is the most complicated operation, there's a little higher incidence of leak. We say 3 to 5%, those are national numbers. Our leak rate is significantly lower than that. Leaks are where the gastric juices are supposed to be inside the stomach or intestine can leak out from one of these sites that this cut and sewn. Again, if that occurs, you need to go back to surgery immediately, find it, fix it, and deal with it. But again, our leak rate for duodenal switch is probably 1% or less. Bowel obstruction can occur with any surgery. Anytime you enter the abdominal cavity for any reason, scar tissue can form that the bowel can twist up on and cause a bowel obstruction. Also, when you alter the anatomy, there's some spaces that the bowel can get in and get twisted. We actually sew those spaces up, but they can still sometimes break down. We don't actually know what the incidence of bowel obstruction is after these surgeries. We think it's about 1 to 3% lifelong. Put that in perspective. The #1 cause of bowel obstruction in the United States is a history of having had a hysterectomy. So any surgery can lead to that type of problem. Protein malnutrition, it depends on how you measure it and which study you look at. It's reported in the literature somewhere between 1 to 25%. In our experience, it's somewhere between 1 to 3%. We sit down, take a careful dietary history, often find they're not consuming adequate protein. Just getting on an appropriate diet is often all that needs to be taken care of, but it needs to be monitored closely. Diarrhea is defined as greater than 7 bowel movements a day. Again, these are national numbers. Again, regardless of what your bowel habits are before surgery, most patients are having 2 to 4 bowel movements a day after surgery, and they find that satisfactory. Probably about a third to maybe even a half of our patients report no change in bowel habit. Again, oftentimes if we're having problems with diarrhea, sitting down, taking a careful dietary history, ensuring that they're on appropriate diet is usually adequate. Sometimes some digestive enzymes, sometimes some probiotics will be helpful as well. Foul-smelling gas, most of our patients don't complain about that. But again, they say if they eat the wrong foods, they pay a price. It gives them incentive to stay on the right appropriate diet. Fat-soluble vitamins, because there are some degree of fat malabsorption, there you are at some risk. It's a very low risk, but your fat-soluble vitamins are vitamin A, D, E, and K. Now, most of our patients are vitamin D deficient before they even have surgery because it's so common in Utah and so common in our obese population. But because there is a risk, the only thing we do nutritionally different with the duodenal switch is recommend you take a special ADEC vitamin twice a day, and if you do that, the risk is very low. So who's a good candidate for a duodenal switch? Well, anybody who qualifies for weight loss surgery is a good candidate. Some insurance companies will not cover it unless your BMI is over 50. But that's arbitrary, and most of those requirements are going away because there's no evidence that lower BMI patients lose too much weight or have more nutritional problems. They don't. But it is particularly, because it's our most powerful tool, it is particularly good for our largest patient, particularly patients with the BMIs in the high 50s, definitely over 60. We recommend patients at least consider it, just because obesity is not a single disease. And if you're one of these really large patients, you have a more severe form of the disease, and it is harder to get your weight down with any of these operations, but this is the one that tends to be the most powerful and get it down the most and keep it down. If your triglycerides are over 600, we recommend that you consider this operation. Again, if you don't know what I'm talking about, you don't have severe hypertriglyceridemia, but if you do, this operation can be very beneficial. This operation is not for the patient that wants to eat whatever they want and lose weight, because you can, but you might struggle with diarrhea and foul-smelling gas and may have other problems. So it is for a patient who's willing to be compliant with the lifestyle. But it's also, we want people to truly understand the risk, because it is the highest risk procedure, although that risk isn't significantly higher. But I want people to understand the risk. But it's great for the patient who wants the highest likelihood of losing all their weight and the least likelihood of it gaining it back. It also is a great option for patients who have had other types of bariatric surgery who have regained their weight. If you have a sleeve gastrectomy, for instance, and you don't lose adequate weight or you start regaining weight, we recommend it be converted to a duodenal switch. You've already done part A, we just do then part B of the operation. If for patients with gastric bypass, if they've lost a lot of weight and have subsequently regained a lot of that weight back, again, this is a good option. It's a challenging operation. It's probably the most, it carries with it the highest risk of any laparoscopic operation we perform, but we do these operations laparoscopically, and it's been shown to be quite beneficial. If you have a duodenal switch and you start regaining weight, we do not have many options. To modify this operation has been shown not to do a lot for weight loss, but put you at significant nutritional risk. So at that point, only medical therapy can be beneficial. The choice is yours. We don't tell patients which operation to get. What our job is, we feel, is to educate you about these three operations so you can make an informed decision about what's best for you, and for us to make sure that you understand it.
So thank you for joining us, and hope that you have learned something new. That's our goal, is to help you feel comfortable with this idea of pursuing weight loss either through medicine or surgery, whatever suits you best. We've talked about some of the different surgical options, what their relative pros and cons are, how powerful these surgeries are, and some of the things you need to be aware of if you do choose a surgical path. Regardless, we want you to know that we care about your well-being and that we're here to serve you.